Thank you, Chair. I'll take about 10 minutes to make this presentation. So in the next 10 minutes, I'll present some of the work which we have done in Chennai on why some people develop complications and why some do not. We know that diabetes is not just a metabolic disease, but it's a vascular disease because it affects every single blood vessel you can think of in the body. It affects the nerves, it affects the kidneys, and so on. Now, one of the reasons why people with diabetes develop complications is the fact that they miss the bus. We often do not realize that there is a long latent period when all the complications start, and that stage occurs about 10 years prior to the onset or diagnosis of type 2 diabetes. This may not happen in type 1, but definitely in type 2. And there is a long period of 10 years before the diabetes is diagnosed. But by the time neuropathy, nephropathy, we found about 12.2% of people have persistent microalbuminuria at the time of diagnosis. And we found about 19.2% of people have diabetic neuropathy as we tested with the nerve conduction velocity at the time of diagnosis. So this is one of the main reasons. The second reason, we know that it is possible to prevent complications by controlling diabetes. We have any number of studies and the follow-up studies and so on. I'm not going into the details. But the fact remains that in spite of the fact that we have so many wonderful drugs, but you can still see that the average A1C in India is 8.9, and the United States is not far behind. They have an average of about 8.6%. So there's a number of studies which have shown that the A1C is quite high, even among patients who are being treated, not talking about the undiagnosed, untreated diabetes. Therefore, I think from uncontrolled diabetes, now we move on to, this was one of the earliest time. I'm going to talk mostly about kidney, where we have some experience. So this was a study which we published in the official journal of the IDF way back in 1999, where we found that if one brother or sister has diabetic nephropathy, the other brother or sister who has diabetes also has a high chance of getting diabetic nephropathy. So therefore, there is a familial aggregation of diabetic nephropathy. Along with colleagues from the Philadelphia University, we first showed in 2001 that there was a particular gene called the ACE gene polymorphism, which predisposes somebody to get diabetic nephropathy. Now, the ACE gene, which is present on chromosome 17, has got two alleles. It has got an DD allele, deletion allele, or an insertion deletion allele. And if you have the DD allele on chromosome 17, then you get a greater fall in your EGFR, even if you treat with ACE inhibitors. This was much prior to SGLT2 inhibitors. Later on, in 2018, we again did the study, and again we found that the deletion allele is quite prevalent among patients who have diabetic nephropathy and who have a low EGFR. With some of the collaborators in Chennai, we also looked at other genes apart from ACE gene, and we found that a particular gene called the TNF alpha gene also promotes diabetic nephropathy because it leads to increased levels of circulating TNF alpha. And this was another polymorphism which we described. There seems to be a crosstalk between oxidative stress and the endoplasmic reticulum stress. And this was shown in one of our studies last year, along with, again, collaborators from Chennai. And we found that the oxidative stress could be another factor. Therefore, there are multiple factors operating in diabetic nephropathy. The transforming growth factor, TGF-beta, produces the mesangial matrix, expansion of the mesangial matrix. And you can see that the TGF beta has also got a gene. And you can see that the mesangial expansion and all the changes inside the kidney are promoted by TGF beta. And we published in 2005, we looked at the serum levels of TGF beta, and we found that those who were on insulin, at that time, we didn't have SGLT2 inhibitors, and those who were on ACE inhibitors had lower levels of TGF beta levels. Therefore, TGF beta levels are an important determinant. Whoever has higher TGF beta 1 levels seem to get diabetic nephropathy much earlier. Quite recently, we also, along with our collaborators in Chennai, we looked at another biomarker called the YKL40, and we found that as the nephropathy got worse, there was a higher expression of YKL40, which is a biomarker for early nephropathy. Therefore, whoever has these biomarkers, genetic polymorphism, seem to be more prone to get diabetic nephropathy. In the last 3 minutes, I'll talk about what about diabetic foot. This is a subject which is very close to my heart, and I do a lot of work on that. So we found that even to get a foot ulcer and an infection and an amputation seems to be having a genetic background. Those who had polymorphisms of the STF1 polymorphism had higher levels of cytokine levels of these enzymes, and they had definitely higher prevalence of diabetic foot ulcer. STF1 stands for stromal cell derived factor, STF1 alpha and beta, and they are small cytokines belonging to the chemokine family. And even they have a gene, as I said, the STF1 gene polymorphism was associated with major amputation. We know that barefoot walking and neuropathy and all that is important, but if you have higher levels of stromal cell derived factor, STF1, and this was published in an important journal called Gene some recently. We also looked at heat shock protein 70, which was also associated with diabetic foot ulcer. And this was published some time ago in 2012. Therefore, even developing a diabetic foot ulcer or an amputation seems to be genetically determined. And of course, we know that there are a number of biomechanical factors. If you have neuropathy and collapse of the arch of the foot, it leads to increased ulceration because of high plantar pressure. So this is known. This is known to occur. This will occur if you have. We showed in 2003 that if you have limited joint mobility in the feet, not in the hands, and limited joint mobility in the feet is determined by looking at the dorsiflexion of the big toe, hallux. And if you can't dorsiflex more than 60 degrees, you have limited joint mobility, and that leads to higher plantar pressures. So there are biomechanical factors which can lead to diabetic foot ulceration and amputation. Finally, last slide, in the interest of time, we also looked at a particular gene which predisposes you to diabetes. So far, what I was talking was nephropathy and about foot. Now, if you have this particular gene called the TCF7L2 polymorphism, then if you have a positive family history and if you have the TCF7L2 polymorphism, you can easily get type 2 diabetes. So we heard that type 2 diabetes epigenetics also plays an important role. Therefore, there are mechanisms which predispose certain people to progress from pre-diabetes to diabetes. And one of them could be this sort of polymorphism. I would like to thank RSDA for this opportunity, and if there are any questions, I'll be able to answer them. Thank you.